Science Foundation.
Yeah, so you might have that.
Are we starting with the verbals?
Yeah, he said
So I'm not doing that. Having a message. I mean, yeah.
You better stop giving up much of that.
No, maybe. Yeah, so I need to wake up again for the things. Yeah. Yeah, same. No matter what is happening around this.
I didn't know I was going to find myself.
When are you planning to do that?
In Malawi. And I get the next week. Maybe if I had been in India, I might have thought, but it's not.
For the future, for the foreign.
I think so. But I just wondered before I had the chance to meet. It's they're being exposed to me. Yeah. Oh wait. But I always start doing. It's kind of like your planning process.
Yeah, it's cool. I mean,
I just did it in prayer.
Yes, yes. Also the time is around there, try to image that space. So I don't have focus in data and focus on they provide and way which is I think other things is like but actually, next is my household. So the number of reasons we know that states that committed always actually eventually we ran cases on this fall that we very basic. It's the only place we buy one.
Because it's only a 1 day.
That's very exactly. I mean, wait, someone.
I think we asked like how many days.
So just seriously.
It's just I want to.
Oh, quite. Just right.
I don't think.
Oh, yes, thank you.
Something like.
I was.
And
Yeah.
great and great attention.
Mr. Glass.
Yes.
Okay, now.
I'll take it out, actually.
Yeah, right.
The same.
Everyone, in your ACC, but no one. It's going to be too.
Yeah, so
They don't completely deliver an opportunity for the public going through my years.
Yeah. That's the way you cross the. In the same situation. Is it the team members are going to kind of northern Europe?
They might be the whole country, but those that have been more than 3 years. Women.
Yeah.
So in terms of constitutional way, women.
Yeah.
Yeah.
Another session will be about. Make sure that we're not. Way. And but there's the different way of why we can physically, we can always see the. But like there's no way of different.
Yeah.
I'm missing the agenda.
Tell me your water, the empty next door.
Yeah. I have some responsible aspects of it. So we're thinking on the second, and you should be sent it really soon because your name's on there, people's names are on there, it's looking for participants. And not just participants, developing it.
You mean again? Yeah.
So each person who attends will have something. So it's not like,
Talk to.
you know, me or others, and things, this will be a danger. So this is something that you're, you know, I might nominate you for the meeting that that's your biggest interest. Not the West side.
I'm not fascinated to know if this, if you have how it is to see. Also bigger than this. I know sometimes like when we experience the no, when I was going using green particularly this step was being nice. We know that they get the access also to the system. Just to compare the source of the
Okay, so individual knowledge. So individual civic writers like theirs.
Where do we, and where do we say this? Yeah, I'll say it. Usually. You want to send it?
And because it does go into the APHRC, I think you're one way, then it's still be broken down, this is you're going to choose, but.
You're a shoot work, like one can compare passive samplers and lab samplers. Passive
Would it be helpful if there was
Out
like
city, you're still in that.
kind of a case? For the
I'm
lab?
sure there's just like. People
Between now and, you know, sometimes like, you know, see what you're saying. to try using some of that data. To understand the sustainability aspects of the impact on service.
Places like. I was really good at my that's I had it really so and sort of yeah so I don't know you know actually it's probably for more than time to I never see it something that we can name perfect that's how
Do I have a doctor?
Yes. Is that, so everything's all set up here?
I do not know. That was, I want to see your did you upload your presentation?
I think so, yeah.
Beyond there, you probably want to check.
Yeah.
Yeah, go ahead. Have you looked? I just uploaded it.
Oh, yeah.
Okay.
It's, it should be there. I mean, it's nice.
We like open all of that.
So they can change the.
I can do it, yeah.
Also, the coverage.
I'm the moderator. Because that is my duty.
I know your name. You could put a joke, but yeah.
Actually, per country, it's a.
When you like a customer.
Service. And right, as you can see clearly that the local tiles are skewed and that's. Lower left tiles of. There's a lot of talk. You can see the equity probably really bad.
You end up.
That might be.
I'm gonna present on something
Actually. Oh, like.
So you were involved in that.
Everyone's information with her. We still really like that, like, so you need to sort of, innovation.
Yeah. Yes, for this morning.
also I don't know I know we're trying to consolidate some slides from Melissa.
I'm sorry.
Yeah.
I am. I'm a professor.
Yes.
Yeah, so I think the process is and you know what's waiting and not what's waiting. So based on the modifications that we do.
Are you liking? Yeah.
My first.
Well, it's training most very close to the American years ago.
Training.
It's more than one, there's a lot going on. It's the most progressive town in the end.
Yeah.
Go find tendency direction. It's definitely not. But like.
Yeah. A lot of.
Yeah. There's never been places that are being said this is still an affordable place to live.
That's true.
One of my colleagues complained, it used to be.
Yeah.
Like, oh, yeah,
I
like,
guess it sounds like.
great. Oh, that's right.
He's very happy with all I know about her is that she's very happy.
I guess.
Based on the.
Yeah.
Anyway,
Have you recruited any students?
I inherited a PhD student. I'm trying to recruit them. I looked at trouble recruiting last cycle. Failed search.
I will pass them to happen when.
Yeah, it's hard recruiting everywhere.
Yeah.
I didn't have a $1 million.
Yeah.
Convinced me why I was.
Should I need to apologize in advance? I'm gonna watch my talk and then leave right when you start talking, I guess, yeah. I have, and Aaron.
Yeah.
I'm gonna try to go rub Bill and I saw her.
Yeah, try what?
Rub Bill and I saw her on the hallway there.
Yeah.
That's why
Yeah. Yeah. I worked with the whole.
Yeah. Yeah, so I don't want to. Yes, I am.
Oh, yeah.
So,
Yeah, I
we can be more of a-
But most of them, they expire.
So, we want to get.
Oh, sorry, you started on
Yeah. Also, it seems like you have to use very. Yeah. Yeah.
And I was.
Service providers, they all go down. What is your background?
Slowly.
Environmental engineering.
Limiting them because.
Yeah.
It's like.
Yeah.
Municipal.
Yeah.
That would.
Yeah, I'm my background. Obviously, I was in engineering.
It's not easy to.
I know, do you know everyone else on my?
Yeah.
She's actually. Engineering and they're gonna have some skills. Younger a little bit. Well, if you don't know so Dorothy is a non-engineer.
So. Everyone like. Excel and there's some. One of those Excel. Students have.
But,
They're. Don't.
actually, they come back.
This is like basic stuff.
Wait, negotiated and, they all like. Friday.
Sorry, I'm late.
No.
I'm keeping time. How long, therefore?
Therefore, we have 3 confirmed speakers. I'm trying to find the 4th one.
Oh, okay,
But so you definitely have 3
okay.
and you can give it standard 12.
Give them 12 minutes to present and then 3 minutes to do question. How do you run your?
I'm a whatever standard.
Okay, well, it's also divisible by the number. So I'll start with 12.
Please.
Have you told, are these the speakers?
Mhm.
Okay, so they're prepared for 12 minutes and
No,
then,
I think they are, but I'll tell them. So 12 and then 3 more for.
yeah.
I can go on, but that's the time for questions and then we'll bring them up back at the end and do a panel.
So I'll do this at 9 minutes.
Oh.
Or we get 3 minutes. Or do you just want 3 minutes?
3 at 12.
Okay, 3 to 12.
Yeah.
Okay,
Let's do that.
great. And I'll be sitting.
Yeah, I'll take, that's my backpack, so I'll sit you now.
Okay.
Minutes. We have a lot more time. But 12 and then 3 minutes. So 12, Catherine's gonna show you.
Right here.
You know, minutes. And then we can decide who's talking or stop and take questions. And then once all the talk is over, we'll invite all of you up and do a council.
Okay.
Yeah. So.
Questions.
But also panel at the end.
But like, yeah, all of them, like, I feel like I was in.
Yeah.
Yeah.
I think.
Do you have Ivy or Chumo in the room? Lots of waving, but not each other. And not- That's okay. Okay, just making sure. We can get started. Thank you all so much for coming. If you don't know, this is Urban and Rural WaSH, and we are officially at half program, which is good. So the rules and the format is the same. You'll have a speaker come up, give their talk, some time for questions, and then towards the end, if we have time, we'll do a panel. So first up, we have Dr. Nadimpalli from Emory University, and she is going to tell us about using wastewater sampling to investigate community-level differences in the burden of antibacterial resistance in a major urban center in the States. So, Maya.
Thank you.
Hi, everyone. Thank you for coming. I have both my postdoc supervisor and the PhD supervisor here. That's fun. I'm a new professor at Emory University. And yeah, I'm going to tell you about this project. So it is focused on antibiotic resistance, which is what I primarily study. Just a little bit of a recap. Antibiotics are used to treat bacterial infections. These are small molecules that we use to cure a variety of pretty common infections, things like UTIs, staph infections, to more serious infections like post-surgical infections. Typically, antibiotics work by killing bacteria or preventing their growth. Now, we are increasingly seeing resistance to antibiotics, so bacteria no longer responding to the treatments that we have traditionally been using to cure them. This has increased for many common infections, so things like STDs, there's a drug-resistant gonorrhea outbreak this year, UTIs, skin infections. Typically, if you have a resistant infection, if there are alternative treatments available, these might be more powerful, more expensive, often can have quite undesirable side effects. This is an extreme case here with colistin. But even in the community setting, for example, here in the United States, a study was published last year saying that if you went to a doctor with a drug-resistant UTI, which is quite common, and you were given the wrong antibiotics, you were twice as likely to be hospitalized. So that's pretty serious, considering medical debt is a major reason people become homeless in this country. And so, of course, the concern with resistance is that as more drugs stop working, more lives will be put in danger. So actually, in the United States, we don't have a very good idea of patterns of antibiotic resistance in the community or who is most at risk of an antibiotic resistant infection. One of the reasons for this is that we tried to kind of get at this data from patient medical records, but because we do not have universal access to healthcare, and healthcare is quite expensive, this is actually not representative of the population. And so one of the goals of my lab is to try to understand if wastewater monitoring could be an alternative way for us to understand patterns of resistance in the community, as well as populations that might be at greatest risk of infection. So we did a kind of feasibility pilot study over the past year in Atlanta, Georgia, which is where Emory is based. We had three main goals. The first was to measure antibiotic resistance across diverse sewer sheds in the greater Atlanta area. We wanted to compare culture-based versus digital PCR methods. Digital PCR is used really often in wastewater monitoring right now to measure SARS, influenza, RSV. It's very popular. And then finally, we wanted to just explore if there were specific characteristics of sewer sheds that might be associated with the detection of antibiotic-resistant bacteria in wastewater from that catchment area. So again, pilot study, small-scale study, we did 3 rounds of sampling across 3 seasons in December, in March, and May of this year. This is a map on the right of the sewer sheds that we sampled. So each polygon represents the catchment area for a treatment plant in Greater Atlanta. We sampled 7 wastewater treatment plants And we also sampled 5 influent lines within 3 treatment plants. So these are kind of like pipes or canals bringing wastewater from smaller subsections of a treatment plant's larger catchment area to a plant. And so we were able to sample them before the wastewater actually arrived at the plant. For the treatment plant samples, these were 24-hour composite flow proportional samples of influent wastewater, so untreated wastewater, and the influent samples were graph samples. And because we were interested in culturing bacteria, we screened the liquid fraction, liquid partition. In terms of what we measured, so we focused on measuring enterobacterales. These are things like E. coli, Klebsiella pneumonia. So human fecal bacteria that live in the gut should be shed in wastewater. And these are also really important causes of infections, especially UTIs in the community-based setting. And for that reason, we focused on resistance profiles that are associated with more complicated UTI treatment. So these are things like infections that are resistant, or bacteria that are resistant to ceftriaxone, carbapenems, and fluoroquinolones. And the media that we use to culture these organisms is listed at the bottom. I mentioned that we also were using digital PCR methods. So we looked at the presence of specific antibiotic resistance genes. We looked for the BLA-CTX-M15 gene. Bacteria that harbor this gene are ceftriaxone resistant. And we also looked for the BLA-KPC gene, which confers carbapenem resistance. And lastly, we also measured bacterial 16S RNA for the purposes of normalizing the concentrations of these resistance genes. So I am going to move on to results, and I'm going to present results from our first 2 objectives sort of in parallel. So first, we detected ceftriaxone resistant enterobacterales in almost all of our samples, 94% of our samples. The media that we were using allowed us to distinguish E. coli, which showed up as pink colonies, from blue colonies, which are a mixture of Klebsiella, Enterobacter, and Citrobacter. So that's why we have 2 panels here. And along the x-axis, I'm showing results for the treatment plants. So we found that E. coli concentrations significantly differed across these sewer sheds, but no significant differences for the Klebsiella, Enterobacter, and Citrobacter. We did find that concentrations of this resistance gene, BLA-CTX-M15, were significantly associated with our culture-based results. Now, this makes sense in the Metro Atlanta area. So Georgia participates in something called the Emerging Infections Program. That's a CDC-funded surveillance program. And through that, we have really detailed information on infections caused by ceftriaxone-resistant bacteria and carbapenem-resistant bacteria. And so with that data, through the EIP, we know that most ceftriaxone-resistant infections in the Atlanta area are caused by bacteria that harbor this gene. So we see that really close association in the clinical setting, and that's reflected in wastewater. In terms of carbapenem-resistant bacteria, this was still detected quite often, although in a lower percentage, 73% of samples. And both E. coli and these concentrations significantly differed across sewer sheds. Now, we did not find that concentrations of the BLA-KPC gene were significantly associated with this culture-based outcome. Again, this makes sense, I think, in the Metro Atlanta area. So through the EIP, actually, they find that about 40% of infections with these carbapenem-resistant bacteria, 40% of those bacteria don't harbor any kind of resistance gene. It's a kind of a mixture of all sorts of different chromosomal mutations that are conferring that phenotype. Of the bacteria that do carry a resistance gene, BLA-KPC is the most common, but there are others. So we do not see a strong association in the clinical setting. And again, that seems to be reflected in what we see in wastewater. And finally, in terms of fluoroquinolone-resistant bacteria, this was also commonly detected, and we did not see differences across sewer sheds, significant differences. Okay, so last I want to show you or share with you results from this final aim. And first I want to talk about why Atlanta is a very interesting place to ask this kind of research question. So Atlanta sewer sheds are very, very different from each other. This is a consequence of decades of redlining, white flight, more recently gentrification, which is associated with a whole slew of problems I'm not going to get into. But from a research perspective, for this very specific question, it's actually a very ideal setting. So to give you an example of what I'm talking about, if you look at Johns Creek, which is a community a little bit north of the city of Atlanta, but like a part of Metro Atlanta, about 83,000 residents according to census data. Most people have completed high school. About a third of households speak a language other than English at home. Very few households living under the poverty line. Now, if we look at Utoy Creek, similar size sewer shed, fewer people have completed high school above the age of 25. Fewer people speak another language other than English at home. About 1 in 5 households live under the poverty line. These areas are maybe 10, 15 miles apart from each other, so very close to each other. And so for this exploratory analysis, we use data from the US Census Bureau, which is publicly available, to extract information about sewer shed level characteristics like the ones I just showed you, but also data related to insurance status, and people's race and ethnicity. We use linear regression models to estimate associations between bacterial concentrations in wastewater from these sewer sheds and characteristics of these communities. And then we corrected for multiple comparisons. So I'm going to show you results now. Remember that these are correlations, not causations. One of the results that we are very consistently seeing pop out is that sewer sheds that have a higher percentage of households speaking a language other than English at home, we are consistently seeing that they have higher concentrations of antibiotic resistant bacteria in their wastewater. And we see this for 4 out of the 5 outcomes that we were looking at. There are lots of possible explanations for this that I am happy to discuss in detail just after. One possible explanation that I'm going to mention is we know that colonization with drug-resistant bacteria is very, very common in other parts of the world. So you can imagine, we know this from traveler-based studies, that if you visit South India or South Asia, India specifically, parts of Latin America, as a healthy traveler, you are very likely to become gut colonized with drug-resistant bacteria during your travels and bring that home. So it's possible that people in these communities are just traveling back and forth, their family members are traveling forth potentially, and that's why we just see more of these bacteria in wastewater. But there are other explanations. Another kind of risk factor that we're consistently seeing is related to crowding. So we're seeing that sewer sheds that have a higher percentage of households that are defined as crowded, so more than, I think it's 1.5 people per bedroom in a household, they also have higher concentrations of resistant bacteria in their wastewater. And we again see this for 4 out of the 5 outcomes we're measuring. Crowding is a risk factor consistently associated with many different kinds of antibiotic resistant bacteria. I don't know if this is working. Okay, so to conclude, we do find antibiotic resistant bacteria of critical concern in Atlanta wastewater. We see that molecular methods might be a useful substitute for culture-based methods. I would argue when a known discrete set of mechanisms underlies most of the resistance you're seeing in your communities. You do need to have some understanding of what's actually circulating and causing infections in your community to make that link between resistance genes and the relevance for public health, I would say. We see that some patterns across sewer sheds are associated with some sociodemographic characteristics. And overall, I think these pilot data suggest that wastewater sampling could be a promising tool to identify patterns of resistance in US communities. Thank you very much.
Yeah, so hi, my name is Javier. I am a postdoc with Rachel Noble at University Unmet University. So I explain all that because I work in a very small community and we do kind of a very similar study to what you're doing, but we're looking at, thank you. So we're looking at I'm not used to microphones. Yeah, this threw me off entirely. So we're looking at kind of the differences between larger cities and smaller rural treatment plants. So we're starting to look at antibiotic resistance. So one of the methods question really, and that's how much did you have to dilute your influent to get kind of a countable culture by?
Yeah, good question. So we initially did membrane filtration, and then we realized that everything had the bacteria we were looking for. So we actually just pipetted out 100 microliters of our influent sample onto our selective plates, and that gave us countable ranges generally.
Okay.
We did a couple of dilutions. I can look into it, but yeah, they're pretty common.
Cool.
Hi, this is really exciting work. I love the culture and molecular combined work. Super useful. A lot of people interested in AMR and wastewater right now.
Mhm.
I was wondering if you are working on looking at any clinical data.
Great question. We just applied for a lot of funding to try to compare what we're seeing in wastewater with UTIs collected by Emory Healthcare. As you might know, only some fraction of UTIs are actually cultured. Many times people just get antibiotics without a culture being taken. And then once that culture is taken, it's thrown out. Emory has a really cool, I forget what they call it, but they have a clinical microbiology core that specifically archives clinical samples of interest to researchers and has the capacity to do that for all Emory healthcare locations. And Emory is one of the biggest providers of healthcare in Atlanta. So we are it's expensive. So we are applying for funds to try to collect those samples and then compare that in real time to wastewater. I agree, that's the next step to try to understand if it actually is helpful. Can you hand this up first?
Hi everyone, my name is Mbewe. I'm a postdoc at NC State. Thank you for your beautiful presentation. I'm also working in wastewater. Did you find out where the sources of the influence come from? Because if you're seeing some of these resistant genes in hospital, wastewater is actually flowing into those wastewater treatment plants, you will be seeing some of these results.
Yeah, so that's a good point. Yeah, there are tons of hospitals all over Greater Atlanta. I will say, and correct me if I'm wrong, but I have read several studies that have, certainly when you characterize wastewater from hospitals, you see a lot of resistant bacteria, you see a lot of resistance genes, but they found that once you get to the municipal treatment plant level, that signal kind of disappears. It's kind of just becomes part of the noise. So we, in this follow-on funding that we've just applied for, we are proposing to consider hospitals and long-term care facilities that are in the catchment areas of these sewer sheds, but I don't necessarily think that that's driving our results, for example. But thanks for the question. There's a question back there. Oh, wait, you have the.
I was just curious. So if you look at some associations between, say, crowding, percent speaking the language other than English home. Do you also see similar trends for poverty or household income as maybe some of these other variables, just proxies for household income?
Yeah, so right. So a lot of the variables, as you can imagine, again, because of redlining, all these things, they're highly correlated. So I have mentioned, for example, speaking another language at home in Metro Atlanta, that is highly correlated with the percentage of population that identifies as Asian and percent Hispanic. Crowding was not correlated with the things that you're describing. That was one of the few variables that we did not see correlations with race, ethnicity.
One last question, Mike.
All right, good question. Did I remember right that Metro Atlanta has a combined sewer system?
Yes.
And so how does that change the interpretation of bush environment?
Yes, very good point. So we normalized the concentrations we were looking at by average flow for these plants. Certainly there are fluctuations as a result of rainfall. Because we're interested in comparing plants kind of at the same time versus looking at differences across time. We accounted for sampling round in our analyses, but that's the best we can do. I think what we would like to do in the future is actually get information for that specific day. What was the flow rate? But that's a little bit trickier for the treatment plants to extract kind of in real time for us. But that's a good point. I didn't mention that. Yeah, we normalized by average flow rate of the treatment plants and the influent lines that was measured as well as the population sizes of the catchment areas.
Great. Let's thank Dr. Nadeem. One more. Okay. We have time. So one more.
I just want to find out something. What do you think about this? I'll just have it simple. We should consider most of the sources which we are expecting are coming from hospitals. If we should consider probably having some from the hospital waste into the community or probably the treatment plant, should there be an equipment to minimally treat or destroy the possible microbes migration towards the treatment plant? Is it possible? Is that possible? Will it reduce or minimize the resistance genes or resistance you are seeing all over? Will it help?
So I think that would be a relevant question if you were concerned about effluent, if you were concerned about what was being discharged from a treatment plant and what the potential, I think, human health implications are aware of that. We didn't measure that.
Yeah, because I'm looking at the transport system from the hospital waste towards the treatment plant.
Mhm.
That time, how efficient, could there not be any lapse in the future where there could be leakage?
Oh, so you like.
Into the direct environment.
Yeah, so that's a good question. And actually, one thing that I'm very interested in is flooding, which is very common in Atlanta,
Sure.
you know, from the
Sure.
combined sewer system. So, you know, I'm thinking about wastewater being a reflection of the community, but that's also a source to the community, some communities in Atlanta, right, due to flooding. I don't know if the most cost-effective solution is to treat hospital wastewater or reduce flooding, which I think would have like a lot of additional benefits.
Well, there was this machine I encountered in Ghana prior to my coming, and I learned that it's still a prototype, it's still under development. So they pass the waste through it, the wastewater through it, and then it's able to destroy even virus. So it just goes through, and I don't know how they call it a filtration machine, but I don't know the principle it uses, whether it uses heat distraction or something, I don't really know. But I was thinking that we could develop something prior to the waste leaving the hospital, it will go through a form of treatment before it gets to the waste treatment plant. And I'm sure, as we said, sea level rise, which could probably infiltrate and get these microbes into the direct environment, probably reaching the treatment can be a problem in the future. Thank you.
Thanks for your comment.
Great, let's try that again. Let's thank Dr. Nadimpalli. Okay, our second speaker this afternoon is Drew Capone from Indiana University in Bloomington. And he will tell us about, let me go to the slide first. Enteric Pathogen Flows at Citywide Scales.
Right. Good afternoon, everyone. We talk a little bit about pathogen flow at citywide scales. I did this as a postdoc with Joe Brown at UNC, collaborating with Nathan Sudapel in Mozambique. So, as you may be aware, pathogen transmission occurs both in the domestic and in the public domain. So domestic is where we live, our public domain is where we work, school, buy things, streets, fields, outside of the home. Interventions often tend to focus on one of these domains, but if we're interested in interrupting disease transmission, we often will probably need to focus on both of these. So this work was nested as part of the Maputo sanitation trial, which tomorrow is the side event. You should come here to talk a little bit more about that. I have a panel, more opportunity for questions. So this is the public domain work component of our 5-year follow-up to our work in Mozambique. And Maputo, Mozambique has both, as you can see on the left, high population density informal settlements. So these are 15 to 25,000 people per square kilometer. And then there's also a cement city downtown that is characterized by apartment buildings and commercial areas. Now, the sanitation infrastructure in these different areas is widely different. As you can see here on the right, there's the blue area, sewer system 1. That is a combined sewer system, and the pumps don't work. They haven't worked for a couple of decades. So all the wastewater in sewer system 1 flows right into Maputo Bay that you can see around. Sewer system 2 is a newer system that is separated. So rainwater and wastewater are collected separately. The wastewater from sewer system 2 flows to the treatment plant that you can see there in the Influenti River Basin. And then the rest of the city is entirely on-site sanitation. So that's pit latrines, septic tanks, as well as the adjacent city of Matola. So the entire metropolitan area is about 3 million people. Everyone outside of those areas covered by sewers are using on-site sanitation. When they fill up and require emptying, that sludge is being trucked potentially to the wastewater treatment plant where it's being dumped. There are no fecal sludge treatment plants in the country of Mozambique. A few are under construction, but the waste is being dumped at the wastewater treatment plant. Yeah. So why did we do this work? Why is it relevant? As many of you are aware, recent health impact trials have shown mixed effects on children's health outcomes. These interventions are often focused on the domestic domain. We thought there might be a need to look at pathogen transmission in the public domain and develop some high-level exposure metrics to better understand how pathogens are moving in the public domain. So our aims were to assess these pathogen concentrations in a wide variety of matrices matched to the excretive flow diagram from Maputo. And then we wanted to do some data visualization to better understand and can compare concentrations using a descriptive analysis between these different matrices to see what we could learn. So if you're not familiar with the excretive flow diagram, here it is from Maputo. It's a modified Sankey diagram where safely managed fecal wastes are shown through the green arrows and unsafely managed fecal wastes are shown through the red arrows. So that goes through the entire process of fecal waste disposal in the city, starting with containment, use for disposal. At a high level, 54% of the waste in Maputo is considered unsafely managed. 46% is considered safely managed, where most safe management is happening because pit latrines are being safely covered and abandoned when they're full. Now, to identify where we could sample, we wanted to sample from every point along the excretive flow diagram. We first met with technicians from Maputo municipality, from drainage and sanitation. They weren't really able to provide us with any maps or data. Their suggestion was just get in a car and drive around. So we got written approval from the city to go around and collect these samples. So we used Google Maps, background knowledge, physically visiting the sites to see where could we feasibly sample and where could we safely sample. And then we implemented this sampling program both in the rainy and the dry season to capture potential variation. And here's a quick glance of where those sampling sites look like. So you have the city here on the left, and then a blowout is around the wastewater treatment plant. So we decided to collect soils from around the entire city. Those are the green dots around dumpsters or dumping sites where solid waste is being dumped in the public domain. We collected surface waters, which there's not too many opportunities to do that in the city. It's basically around before and after the wastewater treatment plant along the Influenti River, and then up along the coast, there's a creek that also drained into the ocean. Red is the open drains that we collected from. We aimed for geographic diversity. So there's also not a lot of open drains in the city. We went up to all the secondary drainage and tried to find all the secondary drains that we could find, as well as the endpoint where the primary drain that's collecting all the secondary drains was flowing into the Influenti River and then sampled there repeatedly. Blue, as you can see along the coast, these are the wastewater outfalls. So as I mentioned, all the wastewater from sewer system 1 isn't going to the treatment plant, it's just flowing directly into the bay. So we drove around kind of looking and trying to find all the outfalls we could find and sampled from those. And then during the rainy season, we were able to collect some floodwaters. We find those as basically standing water, those more than 10 square puddles or small ponds that are more than 10 square meters in surface area. So how do we collect, process, and analyze these samples? All the water samples we collected using the bag-mediated filtration system. So we concentrated these samples out in the field, took them back to the lab, eluted from them, did skim milk flocculation, and concentrated these samples down to about 5 milliliters after concentration. All of our fecal sludge samples we collected as grab samples, and all the soil samples were also grab samples. We cultured fecal indicator bacteria, specifically E. coli, from these samples using the IDEX Quantitrade 2000 system. And then we sent these samples back to the United States. Here at UNC, we extracted nucleic acids from them and then looked for a wide range of enteric pathogens and microbial source tracking markers using a custom TACMan array card. So that card included at least 22 different common enteric pathogens, bacteria, viruses, protozoa, helminths, as well as I mentioned, a few microbial source tracking markers. So what are the results from all of this sampling? I'll start with the E. coli results. So what we have here on the y-axis is our log 10 transformed most probable number of E. coli per 100 mils of water or 1 gram of soil. We collected wastewater influent that was into the plant, fecal sludge that was being dumped at the plant, wastewater outfalls, again, that was flowing into the bay, effluent, which was leaving the plant, open drains, soil from around these dumping sites, surface waters, flood waters, and soils from around the farms as well around the treatment plant. That's our red line is our limit of detection. So anything below that was non-detect. And we did this in the dry season and in the rainy season. So kind of just generally what we'd expect, we found the highest concentrations of cultured E. coli in raw influent, lower concentrations in fecal sludge. There's about a 1.3 log reduction in cultured E. coli from what was going into the plant to what was leaving the plant. And then kind of as we expect, we saw substantial heterogeneity in open drains in our soils. And as you can kind of see there was actually a bimodal distribution in the surface water. And that is primarily because we were sampling both before and after the treatment plant. So very lower concentrations of E. coli in the influent river and elsewhere, and then much higher concentrations of E. coli. This is the discharge point where the effluent is draining right to the bay. And this is an area of intense agriculture irrigation or agriculture production. So influent rivers being used for agricultural irrigation in the river valley. Then with all this molecular data, we're trying to develop what we call like pathogen flow tables, which I'll walk you through those. Again, y-axis is log 10 transformed gene copies per liter of our samples. We collect, these are all the water samples that we collected. This data is ongoing, and there are some other samples that we're going to be adding into this as the data becomes available. We did this for all the pathogens and microbial source tracking markers that we ran using our custom attackman array card. So these are all the protozoan pathogens, crypto, Enteric histolytica, and giardia. And then we overlaid the percentage of safe management according to the excreta flow diagram. So bright green indicates safe management, red indicates unsafely managed, and there's a gradient between them. So a couple of examples that we can pull out from this data that I thought just might be interesting to talk about. One, for example, we found some open drains had enteric aggregate E. coli concentrations that looked quite similar to raw wastewater. I think open drains are more typically associated with Southeast Asia and less with Southern Africa. But what we found is in the high income area where the open drains are existing, we saw a lot of straight piping, which was either raw wastewater coming from apartment buildings, or it was potentially effluent discharge from a septic tank. So even though there was a sewage system in that area, there was still apparently direct discharge of waste to the open drains in some of these settings. Okay. The other thing I thought was quite interesting is if you think back, I mentioned there was higher concentrations of cultured E. coli in raw wastewater than in the fecal sludge. But raw wastewater is coming from middle income, higher income area parts of the city that are covered with sewers. Sludge is coming from lower income areas of the city. So there's some differences where we saw actually higher pathogen concentrations. So we actually saw the highest concentration of giardia in fecal sludge that was coming from lower income areas of the city compared to higher income areas of the city, which are reflective of the wastewater influent that was coming into the plant. And then one of the other points I'd like to make that I appreciate as I was doing this work is if we look at fecal sludge that was going into the plant compared to effluent, that's about a 2.2 log reduction. 2.2 logs is about 99.5% reduction. These types of percentages are very hard to visualize on an excreta flow diagram. So some treatment is better than no treatment, but when we even have a 1, 2, 3 log reduction, it's very hard to visualize that and understand the treatment that's going on behind this to make judgments on what are the hazards associated with these different waste streams. So again, we're developing, and ideally it's a framework to assess pathogen flows in the public domain. This is the type of work we could see being applied to neighborhood level or citywide interventions. We're trying to look at how do these large scale public infrastructure interventions change pathogen flows across the city. This type of work I think is complementary to the excreta flow diagram, it can help us prioritize matrices for intervention. It shows us that some treatment is better than no treatment and complements just the percentage-based system of the excreta flow diagram because we can visualize log level reductions. Obviously, there's a lot of limitations with this work. Our site selection process, it's not random. Like we were based off of what was feasible, what was safe. Our limits of detection were also quite different. Like I mentioned, fecal sludge was grab samples versus our water samples was BMFS. So we use different methods. So comparability can be a little limited based off the methods that we use. This type of work was rather expensive between the BMFS kits, the culture-based work, and the TAC. Our per sample costs were quite high. And unfortunately, mostly due to safety and just being able to get into some of these streams and logistics, we weren't able to measure flow rates in most of the streams that we're sampling from. So with that, just like to thank everybody who's involved with this. There's the MapSand team. I'll take any questions.
I'll start with one. Site selection. Can you tell us about the times that your samples were stolen? And what happened there?
So as I was mentioning earlier, this is part of Galpin Rao's work, where we were trying to compare passive samplers to the bag-mediated filtration system, because obviously, as I mentioned, BMFS is, I think just the kits themselves are like $80, $85 a kit. The bags are not cheap. Passive samplers are pennies. But one of the problems we were into is when you start putting passive samplers in the public domain, people see you putting them in there. We were using these torpedo samplers that look like little toys. So we think either children were stealing them or people just saw us putting these into open drains or some of the outfalls. And they wanted, after we left, they wanted to see what's going on. And they either took them out and left them not where we had put them, or they just stole them entirely. Yeah, so we had to adapt how we were putting these in there to hide them so people wouldn't see them and take them. Yeah.
Wow.
But, yeah.
Questions for Dr. Capone?
Thanks for the presentation. Your notes.
It is working.
Okay, great. To the very feedback. I'm curious if you had an opportunity to share results with city authorities and what kind of response you received.
So there will be a final report that's shared. A lot of this is still preliminary. Like we do have some, I do want to add some of the domestic domain samples. So like we have fecal sludges from on-site sanitation systems, we have child feces. There are some other work that's going to go into this. So we're working with National Institute of Health in Mozambique, and we do have some relationships with the municipality. None of this, the work is ongoing, and we haven't disseminated the data yet with our local, state officials or other agencies, kind of besides preliminary data sharing with our collaborators themselves. Yeah.
Sure.
You had some bimodal distributions with your fecal sludge as well. I saw crypto, for example. Do you have any idea what's going on?
That's because the really high limit of detection. So these were just grab samples. So I was extracting these just from 100 microliters of fecal sludge.
Microliters?
Yeah.
Oh, wow.
Yeah. So I treated it like poop essentially with our extractor kits. Yeah. So that's the limitation was, we were thinking what actually happened is I think most of the emptying in the city, the pumper trucks aren't able to get a lot of the thick sludge out. So they're just pumping out that liquid effluent at the top. So a lot of what's being dumped at the plant was just liquid effluent. If they do take the sludge out, we're actually bagging it up and either dumping it at the plant or taking it to the local landfill. So we got the solids content of what we were collecting at the plant was much lower than what we were collecting from on-site sanitation systems. So.
Battery guy. Hold on. One of the things I was wondering as we were sort of going through this and linking back to the SFD, which is awesome, is so you've got an underperforming wastewater treatment plant, but that's only one piece of the picture. So it seems like you're in a position to say something about how much would it matter if the treatment plant were to be upgraded?
Yeah.
Are you able to make any recommendation based on all this different from what the city of Magoya already knows? Or is it just sort of characterizing a story that's already pretty well understood?
Yeah, so well, I'll make a plug. Let me see if I can. So it didn't reflect. Okay. Well, anyways, I wrote a proposal to do some follow-up work because they are actually rehabilitating the wastewater treatment plant. So the World Bank's invested several $1 million. They're desludging it, adding in tertiary treatment. So that proposal will be reviewed next month, and we'll see if it gets funded. But yes, I think there is some important takeaways here in terms of identifying, are there priority matrices? And part of the World Bank project also rehabilitating drainage, and they're rehabilitating the pumping stations. So there will be an opportunity to get some funding to go do some follow work to look at how did these flows change? Did improvements to drainage, to actually pumping all the waste, capture all that waste and treat it at a different level? How did that impact pathogen flows and kind of these high level matrices throughout the city? Yeah. So. Yeah.
Thanks, Drew. I had a question about some of the pathogens. I know you sort of picked out a couple of the protozoan and the bacterial pathogens, but can you speak to kind of some of the trends you saw with the viral targets? Or is that available?
Yeah, if I can get this, let's see.
And what, like, kind of was it following sort of a similar trajectory?
It's not showing, but
across all
yeah,
of
kind of
them?
technical issue. But yeah, I think generally what we're seeing is in most of these streams, there's a general trend that most of them match. There's not a lot of kind of these, like cryptosporidium was an odd one that we saw much higher crypto concentrations in floodwaters than elsewhere. But for most of the targets, we're seeing common trends that they're generally following as concentrations in sludge and wastewater. You know, there's a 1 to 2 log reduction in effluent, substantial heterogeneity in open drains. So viruses. So yeah, viruses. So yeah, generally in a lot of these, there's similar trends. But then when we get to concentrations that are near a limit of detection, that's when you get a lot of heterogeneity in the molecular results. So like I said, a lot of this is still on, the analysis is ongoing, and the next steps are, you know, just sitting down and working through it and thinking about how we're gonna write this up and what are the takeaways for kind of the city itself. Yeah, and our local collaborators.
Oh, great. Let's stand up to the post. Okay, our final presentation for today is Mr. Joseph Magoya, and he will tell us about improving the functionality of rural community water points through service contracts in Malawi. Okay. Yes, you can.
All right, thank you so much. So from molecular biology and algorithms to community-based management models. So I'm John Magoya. I'll be sharing with you a presentation on how to improve community-based management in terms of functionality of rural community water points through service contracts, a case of Chiradzulu district in Malawi. So I'm working for an organization called Water for People. We are globally in 9 countries, in Africa, India, but also South America. We envision a world where every person has access to reliable water, but also sanitation. So Chiradzulu is one of the districts where we're working in Malawi. It's a rural district, and the district lies on the river plain, but also dominated by highlands and valleys, but also hills. The geology of the district is made up of withered rock and fluctuant basement aquifers. So this type of geology entails that usually when you are drilling boreholes, you are likely to encounter high, dry sites, which we call dry boreholes. So according to the assessment which we did in 2019 as a baseline, we found that access to improved water services was around 89%, and majority of the communities in the district are served through boreholes which are fitted with APHRC hand pumps, about 90%. And again, we had also found a challenge to do functionality of these hand pumps, which was around 73%. And these community hand pumps are managed by a model which is community-based management model. So a set of volunteers that are trained for 1 week to do operation and maintenance. And basically, we have seen low levels of service because of low payments for water service, but also maybe people are running to government for support whenever there is a breakdown to fix. Availability of spare parts is also a challenge, as there was no supply chain for the fast wearing part, but also other important parts to keep the service going. So we, as an organization, we thought of again bringing a paradigm shift. So from 2019 to since 2010, we've been identifying what we call area paved mechanics. These are local masons that are trained to be conducting minor and major maintenances. So the shift has been that instead of just focusing on major maintenances, we are training them to be doing on both routine, preventive, but also major maintenances. So to date, we've identified about 44 AFM mechanics that are being trained, but also equipped in the district to be providing this service to the community-based management models. And they were supported with toolkits and bicycles. And we have two models that we are promoting for our communities, which is annual routine and preventive maintenance contracts, but also major repair contracts. So under annual routine and preventive maintenance contracts, the water point committees go into a contract with this APM and pay a fee of about $10 per year. And the fee basically covers through annual visits where the area mechanic visit the water system to provide that routine maintenance service, replacing the fat-wearing parts. So they use seals, plungers, etc., for a hand pump. But we've also another contract. If the community is not interested in to do with routine and preventive maintenance, which is an ideal to us, which is the most desired one, we also leave them to do the major repair contract, where they normally pay between $26 and $44 per repair. And if the hand pump breaks down while it's under this service contract, the APM will provide the repair free of charge, and the community will only provide the spare parts. But if it's the major repair contract, it entails the community providing the labor as well as also the spare parts for the maintenance to take place. So annually at Water for People, we collect data to measure what we call level of service. So level of service, basically we measure the availability of improved water points or water sources that are meeting government standards. So there are a number of matrices that we normally focus on. So this was in 2019, which acted as our baseline. And when we are measuring, we measure the level of service and we use those color codes. Black, it entails there is no improved water source. Red, it's inadequate level of service. Orange, it means a basic level of service. A yellow is intermediate, and the green, a high level of service. And what we aspire is a yellow and a green, which is intermediate and high level of service. We have also some milestones that we measure. So in this context, that community would want to see 90% of the water sources, community water sources, getting intermediate or high level of service. When we get to that threshold, we know we have achieved everyone. We can move out of that district or that location. So as you can appreciate, in 2019, the level of service was below 60%, where we had a lot of challenges to do with functionality, but also availability of water on the day of the visit. So as I've indicated, from 2019 to 2020, we started promoting what we call service contracts, so that instead of the volunteers getting involved in the operation and the maintenance of the systems, wanted trained masons to be involved in the maintenance of the system, and before that would also improve in terms of functionality of the systems. So these are the subsets of the districts which we call traditional authorities. There are 10. So we started recruiting, identifying and training these area mechanics. So to date, we have done 44. So we started promoting sales contracts in collaboration with the district council, but also some local NGOs in the district. So in 2019, 2020, 201 sales contracts through the promotional campaigns. Then we saw a peak in 2022 up to 1,239. Then in 2023, that data is not a year or complete. It was half year, but also as you're aware, in Malawi, we got affected with cyclone flooding, and Chiradzulu was also one of the districts which was heavily affected. So on average, we've noted that an APM is managing 48 service contracts. But again, from government standards, they would want these masons, these area paper mechanics, at least to be managing 50 water points. So again, we noted also that growth in 2022. So in Chiradzulu, we have about 2,960 something hand pumps. So we've done about 2,100 through the promotional campaigns. So going to the 2 tiers that we are lagging behind as far as level of service is concerned, we are there which is requested. So you can appreciate in terms of the level of service from 2019 to 2023. In 2019, they were below 50%. What was at district level? It was about 55%, and they were over 42%. So when we started promoting, you can appreciate the level of service has improved. Intermediate and high level service over 70%. And again in 2023, year one green again improving, but also the high level of service increasing significantly. And we've achieved, I would say, everyone at committee level, because the milestone is at 90%, and that one is over 90%. Again, also another traditional authority, Mpunga, which had also very low level of service in 2019, around 50%. When we started these promotional campaigns, in 2022, it moved to over 80%. And in 2023, you can also appreciate intermediate and high level of service significantly growing to over 90%. Again, we've also celebrated everyone at tier level. So we want also you to appreciate in terms of the matrices that we normally focus on when we are measuring the level of service. So there are a number of questions that we normally ask, but we focus on these ones for us to appreciate that indeed these communities are enjoying good level of service. So I picked those ones that I feel are linked to functionality of community hand pumps. Number one is the water point system infrastructure being in good physical condition. So you can appreciate from the 2 sections of the district, 2019 to 2023, from 36% and the other one from 44%. Now we're talking at 87%, but also the other tier is also around 87%. The other one is availability of water on the day of visit. So again, you could appreciate in 2019, it was around 56%. Now it's 100% in tier Likoswe, similarly in also tier Mpunga. The other important metric that we normally ask is if the system has broken or being out of service for a day or more than a day in a month in the last year. So we are normally asking the service provider to appreciate functionality. So you can also appreciate from the baseline, we started at 8%, which was really low in Likoswe. Now they're around 84% in terms of that metric. But also in tier Mpunga, we started around 45%. Now it has significantly improved to around 87%. So there are some lessons that we've learned through the process. The sales contract arrangement has also created a platform for continued monitoring in terms of functionality of hand pumps by the district water office through their routine visits. So these APHRC mechanics provide monthly reports on the status of hand pumps within their catchment area, hence also reducing the direct support cost of the district water office in the district. The network has also provided a recognized platform for these service providers, and also eliminating unregistered service providers, which we call bush area mechanics. In conclusion, we noted that there is a significant positive correlation between increased number of service contracts and the improved functionality of community hand pumps, which also translates to improved community water level of service. We're still working on the model, and these are some of the recommendations that we want to pursue in collaboration with the district council. Number one is to establish a mechanism at high level, so to be able to ensure consistency as far as performance functions of these service providers is concerned at a larger scale other than individual APMs. The districts need to monitor to come up with key performance indicators for these APM mechanics, but also to continue lobbying the elimination in terms of debate syndrome for water committees for politicians and government and other individuals for borehole repairs and their maintenance as one way of promoting the service contracts. Thank you.
Question for Mr. Magoya.
For the presentation, good work. I just wondering about, and I apologize if you mentioned this, but how are the payments collected from communities and who's managing those payments? So is it the area mechanics that are collecting the money, managing the service subscription, or is it one of the people that was collecting that?
Great. The actual payments collection is done by the area payment mechanics, and it's the water point committee that are responsible in terms of collecting user fee from the individual households, and part of it is the one that they'll remit to the area payment mechanics. Our role is just to facilitate the whole arrangement in terms of the promotional campaigns, so that people are aware in terms of the existence of these legally or registered area payment mechanics.
Okay.
No PhD topic?
It is. And it was Andrew's, so we'll just trade the microphone back for you. Thank you so much. I'm wondering, do the area mechanics rely on existing supply chains in the area, or does Water for People participate at all in terms of procurement of those spare parts?
Great. So as part of the program, we've also been building the capacity of the supply chain. So engaging what we call shop owners, those people that, providing, selling other merchandises within the community, like groceries, so that they should be also stocking these parts wearing spare parts. But we know within the process, some AFM mechanics have been also stocking the spare parts. But as a program, we thought maybe there could be a compromise to say they are already doing service contracts and them also stocking these spare parts. So they may, just demand from the community, it's okay, this part is not okay, we need to replace, but we have standalone shop owners that are stocking the spare parts, and the program is also promoting these alongside the area payment mechanisms.
Thank you.
Others?
Thank you for your presentation. Could you talk a little bit about how you set the prices of the service contracts for the simple and the major repairs, and how much money that Water for People pay to support this program in the region?
All right. So in terms of setting up the prices, it was done in consultation with the area payment mechanics, looking at the type of work that will involve in terms of replacing the part wearing parts. So it wasn't necessarily Water for People that did the process, but it was the service provider who support from the district water authority. In terms of us support, direct support, ours is just, I would say, direct support in terms of training, but we don't necessarily pay any coin to the whole process. So what is involved in terms of paying for the sales contract is that it coming from the user fee, and the committee will use part of that to pay for the regular visit, but also to buy the spare parts, so that whenever the technician is visiting and they have been advised to replace a certain spare part, they should be able to buy or produce that using their own resources.
So this is full cost recovery for if one mechanic handles 48 contracts at $10 a year, that's $480, right? And out of that $480, you're paying for parts, the labor of the mechanic, and the transportation of the mechanic, and overhead for the.
No, it doesn't include spare parts. So basically, this is the fee, the service charged to the area mechanic. In terms of spare parts, that is charged differently because it will be the responsibility of the committee to buy the first wearing parts. But we've noted, I think, in terms of major repairs, that some communities will not manage to buy, some of the major repairs using the tariff that we collected from users. So in those scenarios, sometimes government will move in to support on the major repairs. But for the routine and preventive maintenances, those are handled by the communities themselves.
Thank you.
So if I may just building on that same, and you had up the slide that for the major repair contracts, the mechanics received $26 to $44 each. And I just wonder that seemed like a huge risk for the actual agent to be taking on, to the repair person to take on. So could you talk a bit about, first of all, how did you get to that number? And if there was that sort of issue of risk that you commit yourself to do major repairs and it could be far more than you were bargaining for?
Great. So as I've indicated, this fee was arrived by the service provider themselves. So in an ideal way, the district council in collaboration with us, we are promoting this first approach of the routine continuous service contract. So all the community needs to go this way. So we believe by virtue of going into the routine and preventive maintenance, they'll keep the system up and running. And if there is any problem, it will be easily detected. Unlike waiting whenever there's a major repair. So that's the fee that the service providers have already agreed. But I believe this is also one way of actually to disincentivize the process. So all the communities should go into this way, and they're able to, minimize the risk of the hand pump going into that route more often.
Anyone else? Do you want a second question?
Yeah, only if no one else has a question.
You're writing a dissertation.
Thank you again. My question is about assessment and identification of what actually needs to be repaired. So you mentioned sometimes the community will call the mechanic and say, bring these parts. In the case of a more major repair, is the expectation that the mechanic will travel, maybe pull the pump, do some kind of inspection, identify the need, and then go make a purchase and come back? And if so, does that get compensated differently to this point about full cost recovery and setting of prices to make sure that they're getting paid for their labor?
So in case of a major repair, when it is needed, the AFM mechanic will go to assess, say, these are the things that are required to have this to repair this system. So it will be the responsibility of the committee, whether to go and buy, or they can engage the same service provider with them to go and buy. But the fee will only shoulder his transport and et cetera, but the materials will be bought by the community members themselves.
Does he charge the fee twice if he comes, they decide to purchase?
No.
So it's one,
It's
even
one.
if he makes two?
It's one, yeah. So.
Okay, thank you.
We have time. So. Yeah.
Well, I think, it's interesting to think about these costs of the repairs. Have you run into issues where the repair is significantly higher, like the cost to repair is significantly higher than $44? Or like, what's the most expensive kind of challenge associated with the major repairs that your organization's seen?
Great, great question. So as I've indicated, that's just an average, but we've noted in some scenarios where you could find that really the repair is beyond even the capacity of that area mechanics. And these are some of the cases that will be referred to the district authorities that they can handle, because even at the level of the community, the spare parts, they may not find, they may not handle them. Like it will need blowing, et cetera, which is need a mechanical process to handle that. But the APHRC mechanics may not have that capacity to handle that. But those we were, agreed upon the type of major maintenances that they can be handled by these APHRC mechanics.
And sorry, a follow-up question to this is actually, a lot of this is on the level of service, but were you also interested or have you looked at like water quality? And is that something you're interested in doing further?
Great, yes. So on water quality, this is not done by the APHRC mechanics, but as an organization, we support during the program running in the district. Annually, when we're collecting the data around level of service, we also do water quality testing. Biological, basically it's biological tests that we normally do. Though sometimes it's on sample basis, but also we encourage the district councils that are also coming in to do routine check in terms of water quality testing. But the APHRC mechanics are only focusing on the
Right, yeah. So just
Yeah, if you want to show the data metrics breakdown, it not measuring it in 2023 brought down the level of service, but if we'd actually done, we haven't done it yet, but it'll hopefully go up once it's happened.
All right.
Yeah.
Go the other way.
So yes, we
Yeah.
yeah. So we also do water quality testing, bacteria, stability, and other contaminant of concern. So you cannot, we've been tracking this and the in 2023 we didn't do any water quality testing.
Yeah, thank you. Just out of curiosity, you said that once water people reaches that 90% level of service, you indicated that they then move on from the projects. But I'm just interested to hear you elaborate a little bit on what's beyond the 90% for the community that has a well.
Okay, so as I've indicated, we normally measure the level of service at 3 levels at community where we check in. So if it's 90% intermediate or high level of service, we assume we have reached everyone, and the 10% can be at the basic level of service. Then we also measure at household level, and that household level is not 90s. We've raised the bar to 95%. Intermediate and high level of service, and the 5% needs again to be basic. And also at public institution is 95% yellow and green, intermediate and high level, and the 5% again needs to be basic. We will not move out that based on community, but also on other levels. So at household level as well as at public institution level. But again, we'll make a decision when we are convinced that the remaining 5% is not, by choice, but, it's by choice, but not other, other elements like discrimination, etc., or they belong to the poor of the poorest group. Then we need to again to support them to make sure that, they're not excluded. But also, we have another tool that will gauge whether these services will sustain themselves, which we call sustainable service checklist, which go hand in hand with this level of service. So whenever we're doing the everyone to check the level of service, we have also the sustainable service checklist, which we have a number of indicators that we check at service authority level to make sure that they're also prepared to sustain all the interventions going beyond the program.
It's actually related to that. So I noticed in Mpunga, sorry if I'm mispronouncing that, from 2022 to 2023, for some of these metrics, there was a drop actually. Like, for example, water system not broken or out of service for 1 day dropped by 10 percentage points. So it seems like there's some fluctuation. It's not necessarily always just an upward trend followed by stabilization. So I'm wondering, in terms of the thresholds you just spoke about, or this checklist you were mentioning, do you collect that data for a few years and look at the average or something like that? Or how do you make sure that numbers aren't going to just drop down pretty rapidly?
Great. So we collect this data annually, but as I've indicated, we also combine the service provider data and the actual level of service for us to appreciate as far as the service provision is concerned. So as your observation is correct, for Mpunga, we noted yes, there's a slight drop between 2021 to 2022, which we had also had to visit further to appreciate because there are some conflicting approaches that were happening in the very same community. Whenever we're promoting the service contract, but also other, organizations were providing another different approach, which affected the uptake of the materials.
Thank you.
You got a question, you got a question.
I can't get back here.
That's over.
Hi, thank you. My question is about the activities that wonderful people did to help drive subscription. That was like a really significant gain in the subscription level from one year to the next. So can you just share more about how you promoted the service and what you think drove community to adopt the contracts?
Okay, so as I've indicated, we're working with the district council, but basically what we noted is that within again the district, we had what we call bush area mechanics. These are just for people we are not trained within the communities that we are also providing that. So what we did was more like to provide an incentive, which is a formal training to these masons so that they will be certified and recognized by the district council. So that was also one of the motivation to the local masons to properly be trained and be accredited, so they look to be formally recognized service provider. But also in terms of from the community members themselves, for them to join this service contract, the district is very close to one of the I would say a business center, a training center. So we've experienced a lot of vandalism happening in the district, which also affected the functionality of the water points. So, which entails many people just coming in to, to maintain the hand pumps. So the promotional campaigns were also based on that. You need to go into a formal contract so that you only allowing people that are recognized by the district council to come and open your hand pump. Other than that, you'll be opening up to people that will vandalize your system. So that has also been a motivation to say, okay, let us probably go into a contract, only allow people that are accredited to be servicing our contract. So those are the promotional campaigns that will be doing. So their work has done be reduced to correction of the user fee from the households. And whenever it's something to do with, looking, servicing the hand pump, let somebody who has been properly trained to open up the hand pump and do the work.
Last question. I'll give a question. The more we talk, the more questions I have. Here a long time. I guess I'm not clear how many communities chose the service contracts. If you've analyzed the characteristics of those that chose the contracts and those that didn't choose the contracts, or did all of the communities in this district have to take the contract?
No, not all the communities. So it's open. It's open to the community members. So basically what happens is when we are done, when many organizations have drilled these boreholes, some will set up will train the water point committee, some will not train up a water point committee. But those that have done even training the water point committees, it's easier to convince them because you have at least a well-structured service provider or water point committee that you are able to link up with them so that you can, persuade them to do a service contract. But we know there are some communities where we have these hand pumps and there is no formal service provider or no water point committee which can, help to mobilize their community members to go into this service contract. So that's another element that we're also doing. I know as Water for People and other organizations, when we drill or help to rehabilitate the borehole, soon after that, we'll, set up this committee, train them properly, and it's easier to negotiate with them to say, okay, there are these service providers that we can go into a contract and they will help you to do this service contract. But those hand pumps that don't have really a formal committee, those are the challenging ones that we still collaborating with the district council so that they can also go into a service contract.
But just roughly, what percent of the communities chose to have a service contract and what percentage didn't? Those that had the opportunity to have a service contract, how many of them decided to do it?
Yeah, so as I've indicated, in Chiradzulu district, we have about 2,900 hand pumps. But from this data, about 2,900, those are what we have already reached them to sign the service contract. So we're over 60 to 70%.
Okay, let's all thank Mr. Magoya. So it's time we close the session. Thank you all so much for coming. Very engaged.
Thank you so much.
It's been a very long time.
Thank you so much. Yeah. Yeah.
There's a lot. Last one, a lot of standing up.
Yes.
I was not.
Ah, great. Okay, great. Thank you very much. Great. Great. Thank you so much. Thank
Yes. Very much. So I really I literally, yeah. Yeah. No problem. So. Yes. You know, I know. Good to see you. Hi. Good.
Yes, but you can give a call.
Now I'm being.
But I can say, I can email you. Yeah, I'll email you so you can get the RFC.
Okay, thank you so much.
I think I like this way. Actually, we'll see, I mean, there's already been happening. One of them being the water. Down the road, I want to go even learn. A lot of people that. Down here, well, they go like, really, isolating everyone. Yeah, I mentioned, and they're. And if they're.
It's. Because now I'm with. Outside, I go to one.
Water, when they have it, not municipality, and they just, I just don't want to. Yes. I, so the thing with number 4, I don't know. I have just like the type of. No, so that's kind of what. Yes, from before, so I, like, yes, so I still am going to like use those and compare, but right now it's really just. Exactly, and so from this past summer. I know, and I also think there's like GTI prevalence in the Galapagos, and so I think they match up, like not like locally have a higher GTI prevalence than normal, because there's a relationship between boating, diving, and like those activities with UTI infections, and I think it just has to do with like holding your bladder when you're out on sea, or like being in wetsuits and peeing at that interaction. So I think that.
I don't know, my main question for you is who is in Malawi, like the people, is this your program area?
Maybe just there's more.
So we have. Yes. Yeah. So.
Well, you're doing, I know that will align like those with me, so I hope to like.
I
hope this is the last.
Well, what I will do is I'm gonna.
When you say
follow up
UTI prevalence was reduced, yes.
We're working with
Okay.
my
Is
degree
that
program,
actually
looking at United Purpose.
Yeah, 100%. There's like seriously.
We have a model where we're.
People
applying for
probably
health
have
care funding
needed
to
to
those
check
programs. It's just starting with it's a limited pilot, and it's gonna run
this
from
is
this quarter
like
to.
antibiotic.
The second half of this year to the
Like
first half of
half
next
the
year.
surveys that we've done to compare antibiotic use in the area, we're seeing like there's so many different antibiotics being used and.
It's being used by a gentleman named Cliff.
But following this, want to also see where the genes are related as
I think
well.
there's a good opportunity for
What's the
us to be involved.
here? Like, so it's like overall UTI incidence is for that, yes, so, but you're like also interested in this additional question of like. AMR, like, I'm interested in the AMR part because I'm. Okay, so let's say.
Yeah, sorry, I didn't.
An area where antibiotics, so heavily used, but you also
So you guys,
have
I
an
mean,
area
you look
where.
into, right?
Yeah.
And so we, I mean,
There
again, it's
may
like,
be,
I'm glad to
I
hear.
know there's
Joseph, I
many
knew you,
different animals.
but I didn't know that you were the one managing this work. We've all our
Mixtures
communications.
do not
company,
things happening there.
We needed to sort of.
I-
work
I want to look at if
We also have
resistant
learning about some of this stuff
genes
too.
in the
Just kind of things,
Galapagos
science members, it's
are
on their knowledge.
comparable
More like
to
Malawi,
UTI or resistant
maybe like
genes
learning exchanges
nationally. And also if the resistant.
Maybe more
or not
time.
nationally, globally, like already have been done consideration, things that you presented on and like what you're identifying as resistant genes. Compare those to some of the resistant genes in the uropathogenic E. coli and see if at the patient level in the hospitals, we can be informative on how they can better treat UTI patients with this information.
Okay.
Does that make sense? Yeah, so it's like two different
The line
things.
is like all the reason why we put
Yeah, I think
contract.
that,
directly
are you
with-
early?
Yeah.
Okay. Sorry for like throwing up all this on you.
No one's doing like the full thing, right? So like
I-
the legal, it's again in the call center, that they don't have like
That's what I
a
have
lot
my
of the data on like.
So
Like just some kind of thing to do, like,
feel like
someone
I'm
managed to
very
think directly there to
microengineering and I
do
like
that.
that like
So like,
center, but
what are the mechanisms?
I think that this is an area of
to put in
at
place
least
to make
20
sure
years of
everything
of
is
research and data, and I want my dissertation to be
appropriately
intervention
funded
focused.
and
And so that's why I wanted to tie in that like AMR, informative, research, at the clinical level that, you know, not just being saying, okay, we think that you should. Like I want there to be.
Yeah, nice. Anything something or data more.
Oh, yeah. I just want that like at the practitioner level. Like UTI patients feel the effects, I don't think they will. So I just want there to be a translational, like.
All right.
I don't wanna say product, but translatable value to clinicians that like they're seeing it, it's like, oh, okay. These in this area, they've identified are the most resistant genes to UTIs.
So do they not do stability testing?
They do not have a, and this is from talking to clinicians, they do not have a microbiology laboratory in their hospital. They have microbiologists, they have many, they just do not have, I'm sure they're doing the culturing, but they came to us and said, we don't have a micro lab and we literally just need incubators.
You guys
Like we have the staff, we have the training, we like. Their main hospital.
Get the subscriptions going. It's kind of alarming.
Yeah, exactly. And
That's a lot.
again, I'm saying this is not, I didn't ask them that question, are you culturing every item, so.
But it's like not
I
at all,
didn't
but
say that
I-
with
it's like the
hesitation, that their answer was just,
Like,
we don't have a microbiology lab in our hospital, and all we need is an incubator to like get that to that level. And I was like,
And then drop off.
that's not that expensive.
My funds are tight.
Right? So that's exactly what, Jill and I have talked about with our funding, just providing that,
I guess so one kind of just thing that keep in mind is, I have previously been told about in settings where people don't have, like clinicians don't have access.
But the next one presenter just like the shot, because then you get more
You
time.
have to be careful when you describe like
Yeah, which one was the
resistance profile in the community or for instance, genes that are circulating, because they might take that information and say, oh, there's an ICU concern with microbiology.
Oh, yeah, the first two ones.
Oh, this is, I better just start.
I mean, it was interesting.
More.
Yeah, you learned
So that not that I presented clinicians, but like I was told by a clinician to be very careful with presenting information.
And I'm on that. I'm not a clinician, so.
Neither am I.
Yeah, so communicating with clinicians, I think. I want to be proactive about it, understand that better.
Well, I mean, like, you think about it from, like, I personally think like arguing, and if you can somehow demonstrate that in this, that it's reducing UTIs, like, there's a huge financial benefit, for all health.
Something I was trying, I just thought about this, like, the other day preliminary looking kind of similarly, I think you took census data and just domestically looking at like trying to get access to UTI cases. And just trying to figure out the relationship between UTI cases, like I think there's something I can do there to tease out maybe like association relationships, you know, that's not just Galapagos in that like
Yeah.
small data set that I do have.
Yeah.
But yeah.
That's really interesting. If you could tie that to like actually people accessing water, and I'm sure he has that stuff.
Oh, Joe must know about
That's
it,
available,
right?
I know,
Yeah,
you know,
that's
like,
definitely available.
thinking about that, how the different areas will actually tracking water in them.
Oh, yeah. Am I in here? Oh, it's not.
Yeah, but in, as long as there's folks in here, let's just make the workshop, and that way we know.
Yeah, it's not.
Yeah.
Oh, yeah. You're
Okay, cool.